So it's a pleasure to be here at the 6th International Symposium on Immunobiologicals. My name is José Cássio de Moraes, and I'm a professor at the Department of Collective Health at Santa Casa de São Paulo. I'm part of the Technical Committee of Immunization in the Ministry of Health. And I'm also part of the technical group for the elimination of measles and COVID. So it's a pleasure to be here talking to you about the control of pertussis, the experience in Latin America. The control of any disease depends on good epidemiological surveillance integrated to the lab. And it also requires immunization provided by vaccine coverage. Unfortunately, since 1916, we've been seeing a decrease in vaccine coverage, but actually this was happening before. So I'd like to, instead of speak about this for 40 minutes, actually speak during 40 hours to explain the fall in vaccine coverage. But we will be talking about issues that are related to the themes being talked about in the symposium. One of the reasons why we see a fall in vaccine coverage is the lack of communication. No communication is being done with the population about the national immunization program, whether it's related to routine vaccination or vaccination campaigns. At this moment in time, we're doing a follow-up campaign related to measles, and we're doing indiscriminate vaccination for those who are less than 5 years old. And this has been done together with the influenza vaccine. So the lack of communication makes it so that these campaigns end up being secret. So very few people actually get to know about the existence of these campaigns. Another aspect which is important to explain this fall in vaccine coverage is that as we saw an expansion of our immunization program, it became necessary to apply multiple vaccines in the same session. So with 2 and 4 months, we use the pentavalent vaccine, an inactivated oral vaccine, the pneumococcus vaccine, and the rotavirus oral vaccine. So this multiplicity of vaccines makes it so that the vaccinator or the representative of the child, which is the person who takes the child to the clinic, it makes it so these people end up being hesitant about the application of 3 vaccines in the same session. There's another aspect which is related to the fact that the pentavalent vaccine which is made from whole cells, there are many adverse events related to it. And this happens more in relation to the other vaccines that are used in the same session. So the fear of adverse effects may also explain the fall in vaccine coverage. And the state governments and federal governments and many cities don't provide any training to help minimize these adverse effects. So one of the alternatives that we should discuss, and again, this is an important discussion for us to modernize our national immunization program so that it may become a program of excellence as it was during the past. Because after all, next year, we will be celebrating the creation of the national immunization program. We will be celebrating 50 years. And I hope that we may revitalize this program and bring it to the achievements of the past. So to debate this issue related to reduction of adverse effects and to discuss the use of combined vaccines, we will discuss the hexavalent vaccine. So for the hexavalent vaccine topic, we have two speakers. We've got Ana Paula Burian, who's a pediatrician, infectologist, and coordinator of the Reference Center for Special Immunobiologicals in the state of Espírito Santo. She's a participant of MediaTech, and she's also president of the Brazilian Society of Immunization of the state of Espírito Santo. And we also have Juan Pablo Torres Torrente, who's a pediatrician and infectious diseases doctor. He's an associate professor of the Department of Pediatrics at the Luis Calvo College in Santiago. So their presence will bring quality to our symposium. And so I would like to invite Ana, so that she can present you her material. So thank you, Ana. Good afternoon to everyone. I'm going to talk to you about immunobiologicals. I believe in vaccines. The speaker is speaking very low, so I can't hear her properly. Unfortunately, at this moment, people haven't yet vaccinated for measles and the flu. And now there's the availability of pertussis, because we can actually infect our patients with pertussis, and a lot of healthcare professionals don't know this. So here in Brazil, we have a population of almost 215 million people with newborns, almost over 2 million newborns, and premature babies represent 11% of that. And our private system includes some vaccines, but we have a unified health system that provides a lot of vaccines for free. So our system provides everything to everyone, but we want to give more for those who need it most. So since 1993, the patient can go directly to a specialized center, or they can make this request for vaccine remotely through the different coordinating bodies of immunization. And today we have 52 CRIEs in Brazil, and this number has been increasing because of some financial incentives that the National Immunization Program has been trying to provide. But unfortunately, because of bureaucracy, the state of Espírito Santo, which received almost 900,000 reais, wasn't able to increase the only CRIE that exists in the state. So since 1976, we've had a combined vaccine, and since 2012, we had a pentavaccine. So the CRIEs appeared in 2001. So we had the DPA vaccine, the cellular vaccine, that was provided for serious adverse events. So convulsion up to 72 hours after the pertussis vaccine, or as a result of hyperresponsive hypotonia syndrome. Then some other comorbidities were added. Since 2014, we've had the addition of immunosuppressed population. This is for people less than 7 years of age. And since 2014, we also had the pertussis vaccine. And in 2021, the hexa and penta acellular vaccine was introduced. So how does the notification of adverse effect happen? Well, anytime any patient has any adverse effect, they should be sent to the service where they receive the vaccination, and the notification will be filled in, and the vaccine will be changed. And sometimes there's a bureaucracy because of a lack of knowledge that regarding the fact that the health clinic needs to fill in a form, and sometimes the doctor doesn't know about it either and ends up forwarding the child to the CRIE. Sometimes these children end up in a limbo of a system where, because of a lack of information, the mother ends up being scared and doesn't complete vaccination of the child. So in our technical note for the implementation of the vaccine, we have this information. And here, besides the criteria for the different vaccinations, and what we have today is the Hexa vaccine. In the past, we had the Penta, but it was substituted by the Penta. So around 15% of people talk to us because of adverse effects, and most of these people do this at the CRIE. And this is a result of prematurity. So we end up working more with premature babies, and to a lesser extent with adverse effects. When we list the advantages and the challenges, we've got the several applications. And we know that, for example, very small children and premature babies, they have a risk of apnea because of any kind of stimuli. So the more I provoke pain, the more I can have an adverse effect, especially in premature babies. The greater number of visits to a health clinic, then the more difficulty that I'll have with adoption. Sometimes we also have a lack of supply. At the CRE, before 2021, we had DPTA with one injection, hepatitis B with a third injection, and inactivated polio with a fourth vaccine. So a lot of times we weren't able to do 4 injections in a small baby, and that baby sometimes would go to take DPTA and another vaccine would be missing, and so this made access more difficult. At the end of 2019, from September onwards, there was a shortage of the Penta vaccine in the basic health service. And this demand, and so we ended up compensating for this afterwards. And now we have a large number of children who are late in their vaccines. And sometimes the basic health service does not know how to use minimum intervals, even though there has already been some publication from the Ministry of Health related to that. We want to make sure that we accelerate the protection of these children. So today we can apply an acellular hexa vaccine instead of the 4 injections that we used to use in the past. And this simplification makes things easier. So today we can offer at the CRIE a smaller number of injections, less trauma for the family. And so the families can actually follow the vaccination scheme and do it on time. So here we've got the manual of adverse effect. This comes from the last edition from 2020, and it talks about the instance not only of different issues, but also convulsion. So we've got hypotonic episodes for every 50,000 injections, and we've got publications that refer to this. Hypotonic incidents are where the child almost faints after an injection. This can happen at the family health clinic, but it can also happen when the mother is already home. So the child may present cyanosis or generalized hypotonia, and this is a relatively benign event because if the family gets information about this, there won't be any problems. But a lot of times, neither the vaccinator nor a professional at a family health clinic will know how to identify this issue, and they won't know how to tranquilize the family because a lot of times this is confused with convulsions and anaphylaxis. There are a lot of children who even got adrenaline and corticoid because people didn't know how to deal with this issue. So sometimes we ask ourselves, do pediatricians know how to identify, conduct the child, notify the event, and orient parents? In most cases, the answer is no. Regarding other incidences of adverse effects, we see that a lot of these events are not even completely evaluated. These conditions are not well known. So it's not enough to know about incidents. We also know how to conduct these issues. And then we have a paradigm, because in some situations we have a child that comes into the basic health service and nothing is known about them. But we also have a problem where today everything is an issue related to vaccine. So we even had carcinomas being confused with adverse effects as a result of COVID vaccines. And this is because differential diagnosis wasn't done. So we have this duality. Sometimes we don't know how to recognize what's related to vaccine, and sometimes we have the opposite. We think everything's related to the vaccine. Here we have a publication from Dr. Renato Menezes from 2007 that mentions the same literature, that mentions the same incidences. And the results show that the penta from whole cells can be used safely in the National Immunization Program. And we've got the incidence of hypotonic incidents and convulsions, which was very similar to what was published in the 2020 manual. This was also close to what we saw in the state of Espírito Santo. We did a survey of the whole state of Espírito Santo. In 2019, we had 120,000 doses of penta being applied, and we've had just 73 serious doses. And when we lowered this, there was a lower incidence. When we separated the children smaller than one year, we found less episodes, serious incidents, and within these, we had just 10 convulsions. So 1 for 2,000 when we evaluated only those younger than 1 year old.
We also found a greater number of penta application 2020, but remember that the end of 2019, we had this lack of pentavalent vaccine. So we had this pent-up demand from 2019, and we were able to survey the 2021. And now we are compiling this history of the last 5 years. So the great majority was with the first doses, almost 70% of 3 years was hypotonic and co-responsive episodes, and many of the children needed medical assistance. So our concern is to train this medical assistance. We have to remind you that these children are not seen, not even by a pediatrician, a generalistic physician that won't have the knowledge on vaccine that we need for this robust calendar that we have today. So we need more training on adverse events and vaccines. So the flow of care is this one. We have to remind you that they should vaccinate it in ICU as well, because they can get diseases, and COVID have shown us that the UCI is not a protective place, and we need to vaccinate these children when they are in hospital. And for several reasons, this vaccination is postergated, and sometimes they survive well and with no adverse effects, but they are unprotected in our country. And this request can be asked to CRI via municipal coordination, in which CRI has a system of direct application, and we also liberate the vaccines online in different municipalities, and that works very well if you organize the flow well. As a conclusion, we understand that the prematures have great risk for getting disease and adverse events, and they can benefit with combined and cellular vaccines. And we have to organize the adverse events, because we know that there's this sub-notification, and because people are not aware about the problems and they don't know how to notify. So when this flow happens, it is with a form that is not well filled up, and that can happen at any moment when we administer, and it's more common in the first doses. So that requires medical assistance and guidance, but we need training for the physicians to be able to identify and calm down the family and treat the child, so that the child can receive other vaccines. They should receive pneumococcus, meningitis, and other important vaccines. And we have to think about different criteria. We have this meeting with different CRIs to increase the age range so that the premature babies can have this extended application. And we have to understand that is our mission is that we have to learn with our children, and we don't have to, but we have to take into account the differences between different babies. Thank you so much. Dr. Juan Pablo. Hello, good afternoon. How do you do, doctor? It's a great pleasure to share with you in a virtual way, but it's a very important issue that is the infection and prevention of the pertussis disease. Can you confirm if you are able to see that well? Are you able to see the presentation correctly? Very well, thank you. Well, my presentation after the speech of Dr. Burian is about the hexavalent vaccination and how it was introduced in Chile. And I'm going to talk about the basis and results that we see in our country. Here you may see my conflict of interest. And I'd like to say that in Latin America, in almost all of the countries as well, there's a scheme, vaccination scheme with pentavalent vaccines with full cells at 2, 4, 6 until 18 months. But there are 4 countries, Costa Rica, Mexico, Panama, and in South America, the single country is Chile, that also have the hexavalent with the acellular component, that is the Acellular combined hexavalent vaccine. And we know that besides the premature babies, the most affected in cases of pertussis are the babies who are less than 1 year old, especially if they are less than 6 months old. So in Latin America, 1 in 3 cases of pertussis happened with children who were less than 3 years old. There's a recent article that was published on a Chilean magazine on infectology about that. And we noticed that that's happening not only in Chile, but also in other regions, as in Brazil as well. And we are able to observe that in babies who are less than 1 year old. So what is the Chilean experience? 2 and 3 years ago, Chile, as the other countries in the region, were vaccinating with pentavalent vaccine, but plus oral polio. But the pertussis dynamics follow this logic that is repeated in different countries with acellular and cellular pertussis vaccines. And in the case of Chile, the last outbreak, the last increase of cases happened in 2012, not only Chile, but also other countries. While Chile maintain a vaccine with full cells. So between 2015 and 2016, when the pentavalent vaccine was changed its supplier, we have observed an increase of 85% of the effects attributed to vaccination, and mainly apnea and also in premature babies where this increase was a 400%. And that could happen in other national programs. For instance, in 2018 in Uruguay, we had cases of hypotonic and hyporesponsive syndromes that increased in a meaningful way, also related to the change of the branding of the vaccine. Or what happened recently in Brazil, where concerning pentavalent in some different batches that had quality problems in its liquid. And then we had a reduction in the availability of the vaccine because these batches were not used. So it's very important to have proper vaccines to prevent this kind of problems that could impact in adverse effects or in the diminishing of coverage. Therefore, Chile, well, as a country, we are in line with the strategy of eradication of polio. That is, we have to use the injected polios, and the adverse effects that were observed with the pentavalent vaccine changed the recommendation of the Ministry of Health. So Chile now is using 4 doses of hexavalent vaccine combined in a gradual process. We had a transition in 2018. We started with the cellular hexavalent vaccine, and then in 2019 we had the full scheme with the full cellular hexavalent vaccine with 2, 4, 6, and 18 months old. I would like to mention the impact of this transition of this scheme with this combined Acellular hexavalent vaccine. We must maintain the trust of the parents. We have to maintain the coverage. We have to reinforce the risk group of premature. And also, I'd like to talk about costs and regional recommendations. Concerning the adverse events, we know that in Chile, we had adverse events from vaccines for children. The infants, 70% that are reported in babies who are breastfeeding, that corresponded to the use of full cells pentavalent vaccine. So we had this increase of adverse events. We had 16 apnea events. So this change to a cellular hexavalent vaccine brought some changes, and we were able to publish them in this article where we compared the frequency of the adverse events. So in 2020, we had the full transition with the Acellular hexavalent vaccine, and we compared what was happening with the full cell vaccine and the Acellular vaccine. You may observe that as time went by, we had a gradual reduction of the adverse events. On this graph, you may see the increase associated to pentavalent vaccine in 2016, and in 2018, in the transition when the children received with 2 and 4 months the combined hexavalent, and here the full scheme, we see a reduction, and we came to 2020 with this great reduction, even better than 2015. So we had a reduction of adverse events, not only in lactating babies, but also premature babies who were receiving the full cell vaccines. So now we see the opposite, the premature that were receiving full cell vaccines against pertussis, they had adverse events reported as serious, and if they received cellular vaccines, only 25% presented adverse effects. Another very important aspect is the trust of parents. In Chile, we also had a study led by Dr. Miguel Orion, where we studied in this transition when we added the Acellular hexavalent vaccine, we had the satisfaction and acceptability from parents and caretakers. So as we've mentioned before, in 2018, the children received the combined Acellular hexavalent vaccine. And then we had the study, an arm that was receiving this oral polio vaccines in this moment of transition, and the other arm when the children received the Acellular hexavalent vaccine combined when they were 6 months old. So we had the follow-up in the questionnaire for the different parents, and the parents of arm 2 were more satisfied with the vaccine experience. And what's most important, 94% said that they would return for the next dose. And this is very important for coverage. They were going to bring their babies again. They thought the process was very easy, stress-free, quick, and the multivariate analysis confirmed that ratios, satisfaction ratio, they are willing to bring their children for the second doses. It's very interesting that we had a different impact in real life in terms of satisfaction and the desire to vaccinate again. Concerning the coverage, we know that in our region, we could have a greater coverage, and the pandemic made the coverage of the third doses diminish of DPT, and it's even lower for the boost doser at 18 months, but we are less than 90 and less than 80% at DTP4. And this is concerning. Some data for Brazil, for DPT1 and DPT3 in for lactants, we have figures in 2019 around 79% and 67%. So we have to make an effort to improve the numbers. In Chile, when we had the pentavalent in 2018, before the pandemic, we had a coverage that I would say were proper, not optimal. We had 93, 90, 85, and 78% with pentavalent. That was the first semester. Pentavalent plus oral polio. When we changed to hexavalent, the numbers increase, and we end the year 2019 when we had hexavalent with 2, 4, 8, and 18 months with these figures. Therefore, we had a good response. But the pandemic made us have a lower coverage, especially 70% of the children who were 18 months old. Once we could reopen the vaccination centers, what happened in 2020 and also in 2021, we were able to recover the numbers, and we got to 98, 97, 94, and 84%. And the hexavalent coverage at 18 months. And this is superior to the 2018 values, although we haven't concluded the pandemic. This data show the coverage. I cannot say that the coverage has increased only because we've used an easier vaccine to administer that is ready, but these are the data that we have in real life.
We can't forget the premature babies in the transition to the hexavalent vaccine at 2, 4, 6, 8, and 18 months. Before that, the Ministry of Health issued a decree where they said that before this, all the babies younger than 37 weeks could receive the vaccine. This strategy doesn't work for everyone, but sometimes we can have specific strategies for the at-risk groups, such as what was done in Argentina. We also had a similar experience in Brazil, and Colombia is also doing something similar with premature babies. Lastly, regarding the costs, it's true that those countries that can make a decision to have the combined hexavalent vaccine, basically this vaccine is more expensive than a pentavalent vaccine with wholesale fragments. But we've had this experience in Chile. Here we can see the changes and we can see the investment, the increase of the national immunization program in the country before the pandemic. But this experience was published in a study regarding the cost minimization. And this was published in a Chilean magazine. And then we've got another evidence which shows the same results. When there's a change of component from wholesale to acellular, we can save we can save money related to adverse effects, logistical issues. So if we turn this into numbers, the cost of vaccine ends up being this here. But when we do an estimate, considering the other costs, the cost of decision becomes more interesting. So Chile decided to change to a hexavalent vaccine because of integral reasons and not just because of pertussis. We basically needed to have a schematic where we had polio vaccines and injectables. Adverse effects were also important because we saw an increase in them amongst premature babies. There was the issue related to safety. There was economical pharmacoanalysis. And also because all of this is important for public-private equality. It was important for all children to have access to these vaccines. Amongst the recommendations of a group of specialists from SLIPE and ALAPE was the use, preferably, of vaccines, acellular vaccines to reduce the number of injections, to improve acceptance, and to make the logistics of administration of vaccine easier. So the Chilean experience can be useful for other countries in the region. We believe we can optimize with the combined hexavalent vaccine, we can improve the coverage and reduce the number of visits and of adverse effects. This also increases the trust of parents. And all of this is based on a very well-designed event. So we need to have strategies and vaccines that can improve coverage and advance this program in our region. So thank you very much. And now I'm available for your comments or questions. You, so can you describe what it was like to convince the government to change the vaccine from a cellular vaccine to an acellular vaccine? Because we're going through this process in Brazil. So what was the Chilean experience like? Well, I think there are various factors related to this. Amongst them is the integral decision. We're not receiving the audio correctly, I'm sorry. So the sound is getting cut off. Apparently the speaker has a bad connection. Sorry, we are unable to receive the audio to translate it. So there's a lot of oscillation. As soon as the speaker's connection is reestablished, we will continue the translation. Juan Pablo, we're having connection problems. Your sound is oscillating too much. Yeah, apparently there's a problem with your connection. We will try to reestablish the connection. Could you please summarize in a few words what you said about the process? Would like to apologize. Okay, sure. So to summarize, this is an integral decision. There's not just one factor. We need to be on the same page regarding the polio vaccine. And there was also a media issue. There was the adverse effect in a very susceptible population, such as premature babies. And the government authorities also needed information related to the reduction of costs. So based on the evidence of what happened afterwards, we confirmed that we suspected there was an impact in vaccine coverage and there was a greater amount of satisfaction and coverage. And that's because the costs were those that were estimated. And there's also the issue of public-private equity. So today we can see that the decision had positive results. Thank you, Dr. Juan Pablo, for your presentation. Can you hear me? I would like to ask you, or rather, Chile's decision is interesting. This issue for the Acellular vaccine with IPV, this is interesting. This was the justification for this introduction because your presentation mentioned adverse effects as a result of the whole cell vaccines, but at no moment in time did you say anything about efficacy or effectiveness of the vaccines. Was that not discussed? Was that not important? Was not important to know and have efficacy and effectiveness data related to the vaccine, both for the wholesale vaccines, both for the wholesale vaccines and the acellular vaccines? Although I believe that there's a justification to have acellular DPT. There's a combination that probably allowed you to have greater vaccine coverage. And I'd like you to talk a little bit more about this theme. Yes, thank you. That was a very adequate question. Without a doubt, in any vaccine analysis, we need to consider safety, immunogenicity, efficacy, and effectiveness. I didn't detail this because we already know that the effectiveness and efficacy that was observed in the real world in different countries that utilize wholesale vaccines for pertussis and vaccines that use acellular components, we already know that these vaccines are adequate and they're comparable. They're also similar in terms of the immune response that they can generate. The focus of my talk was who needs the protection most. That's basically babies who are less than 1 year old, and especially those who are less than 6 months old. We know that both the pertussis vaccine based on whole cells and the acellular vaccines have an efficacy that's very adequate, and they're very comparable. So even though these are very relevant points, there wasn't a lot of difference between the two because both showed good results. But when we analyzed what happened in relation to adverse effects and the consequences of that for vaccine coverage or for the perception of parents and their willingness to vaccinate their child and to continue vaccinating their child, basically all of these factors were the factors that show the difference when it came to the parent's decision. Okay, so it seems like his internet connection improved. Okay, so there was a question done by Luciana Brito, and I also have a question. So basically we have an old patient who was diagnosed with pertussis, and the doctor's recommendation was that both the mother and the child receive DPT vaccination and pertussis after the disease. So how do we counsel this case? And the other question is, do we have information to evaluate the coverage of the hexavalent vaccine for premature babies in Brazil? Well, we've got a bacteria, a bacteria infection that has to be treated with antibodies. So I would vaccinate the child of the senior citizen, and the senior citizen can be vaccinated sometime after she recovers from the disease. Unfortunately, the vaccines for these two diseases are not available at the Unified Health System. DPTA is available for adults, for health professionals, for gestating women, and also those who went through bone marrow transplants, so they can get a dose of the vaccination at CRE. Now, some CREs, we can get a large number of reports at the CREs. However, we have a lot of difficulty in finding these reports. And that's because some people don't know how to use the tools that they have, or because sometimes data is entered incorrectly. So at our CRE, we can find this information. We can look for information based on criteria or based on indications. So I can look for premature babies. I can look for information based on adverse effects, and also I can look for information by age. But when we send a vaccine to the countryside of the state of Espírito Santo, and this happens all over the country, over there, they're not able to use the same kind of rationale for entering information. So sometimes they'll create inexistent criteria, and so you end up having a hard time looking for information. So today, the National Immunization Program can't do a coverage based on criteria of the CRE. We would love to have this data, but unfortunately, we haven't been able to get it in all places in the country. Do we have any more questions for Juan or for Ana? So I would like to thank you for your brilliant presentations. And I hope that the implementation of the hexavalent vaccine may leave the CRAs, it may reach the general population. And I hope that we may learn the lessons from Chile so that we can also change and modernize the national immunization program. So thank you, Juan. And it seems like we have a question. No, actually, the light is too strong. I can't really see. I'd actually like to make a comment. I endorse the issue raised by Dr. Akira about the efficacy of the acellular vaccine versus the cellular vaccine. The data are very clear, especially data coming out of Australia. The data shows that there's a very large difference between the two vaccines in children who take the acellular vaccine and the children who take the acellular vaccine. There's a difference related to the wing effect. That is, the loss of efficacy happens much more rapidly when you use the acellular vaccine. We understand the issue of reactivity of the vaccine. So I think it's a balancing act, but there is a large difference in relation to the efficacy of the two vaccines. I'd like to make a comment. Okay, thank you. So yes, I think that, as you said, there is a difference in the duration of the immunological response when the child receives the acellular or the cellular vaccine. There are two important topics. We have to insist on the clinical aspect. This waning effect is observed years after vaccination. So we want to try to prevent serious infection in children who are younger than 1 year old or younger than 6 months old. So with both vaccines, this is possible. So in children who are this young, there won't be a difference in the effectiveness of vaccines. And last year, there was a study coming out of Poland, and it was done with children who received a priming of the vaccine. And then when they were 5, they received the vaccine based, the acellular vaccine. And it was observed that after 4 or 5 years, there was no difference in the average of antibody levels. We know that there can be different immunological responses, but as pediatricians and as infectologists, we can say that the biggest problem is within children who are less than 1 year old. This is the case where effectiveness and efficacy, the efficacy and efficiency is similar. Of course, if we look at children who are older, who are 10 years old or 14 years old or adults, this might be a different issue. But this is not the group that will suffer an impact from the twins. So, and we know that we need to have an effect from vaccine related to pertussis in the adult population. Does anybody else want to ask any questions? Okay, so we would like to thank everyone for their presence. We'd like to thank Juan and Ana for their presentations. And let's continue in this path to modernize our immunization program. Let's try and eliminate the oral polio vaccine. I think there's a consensus amongst many specialists about that, and Dr. Akira is amongst them. And let's introduce vaccines that are less retrogenic, and let's find combinations of vaccines so we can reduce the number of visits to health clinics and vaccination centers, and so that we can also reduce the number of shots that these children receive. So thank you very much for your attention.